All right, well, it's my pleasure to be here with you. I want to talk to you about something that I've spent at least the last decade of my life trying to understand. That is GERD in the 21st century. And the story really begins with OMEPRAZOLE. Where's my pointer? 1989, the first proton pump inhibitor, OMEPRAZOLE, was approved in this country. And this is just a sketch of the isomers, the R and the S isomer. And subsequently, it was learned that the S isomer, that is S-ISOMERS, had much greater potency than the racemic mixture did. So this drug was born, but we now had a mechanism by which we could control acid secretion. When I was a fellow, we gave antacids. Don, you don't even remember this, but 7 doses a day. Came out of Dallas, actually. 7 doses a day. We'd give 1 hour and 3 hours after each of 3 meals, and a 7th dose at bedtime. And with that, you could keep the acid relatively controlled. Along came drugs that would truly control the acid. And one of the results was that we unmasked the concept of non-acid reflux. We really had no way to really identify it or to even suggest it. So just recently, from University of North Carolina, publication in Gastroenterology, a commentary which basically made these statements. The patient population presenting to gastroenterologists for symptoms of GERD has changed. GIs now only enter the scene after failure of PPI therapy. That was Nick Shaheen and Dylan in 2010. I often like to ask people that are practicing GI, when was the last time you saw a patient that wasn't already taking a PPI? Not very often. Think of your clinic. So that's basically what we're talking about again, is this guy. And the history I like to give is he's in his 50s. If you ask him when his GERD started, at most of his adult life, probably when he was in college, and weekends with pepperoni pizza and beer. It got worse over the years. Somebody put him on a PPI 6 years ago, and the burning went away. Common story. Take care of the acid, take care of the burning. But he still complained that when he would eat too late or too much large meals, he would have a regurgitant type symptom, sometimes taste material back in his mouth, and a little bit of a chronic cough. So symptoms that might be due to reflux despite PPI therapy. And you know the list. The definition of a PPI failure or partial responder would be somebody who has no response or a partial response of suspected GERD symptoms to PPI therapy. And the list looks something like this. Most, for sure, top of the list is the question of compliance. First thing you do is to check your patient, make sure they're taking their meds. Make sure they're taking them right. So either they're not taking it or they're taking that evening dose at bedtime. Very common thing. All you often have to do is just adjust the dosing. Maybe they're taking the wrong PPI. That's just to remind you that they are not all the same, particularly not in different patients. And I'll come to that in a minute. Maybe it's not a GERD symptom, so it's a wrong diagnosis. Maybe you haven't controlled the acid. And almost everybody in the room here has been in my clinic with me, and you know that often we'll say, well, the first thing to do, let's get the acid under control and get that out of the equation so we have a better idea what we're dealing with. And then finally, maybe you haven't controlled the reflux. In other words, there's symptomatic continuing non-acid reflux. So we first got into this in the early 90s as omeprazole became routinely available. And here's a study. Brad Quo was a medical student from Jefferson. He's now an associate professor at the Harvard Service, Mass General in GI, fortunately. Brad came and worked with me for a year, and we were interested in this new drug and how effectively it controlled gastric pH in a group of normals. Well, they were Jefferson medical students, so I don't know if they were normal or not. Ira, what do you think? Now you wouldn't be one of them. You were too far along by that point. Anyway, a group of Jefferson medical students that Brad and I got together, we put them on omeprazole 20 milligrams twice a day, before breakfast, before dinner. And on the 7th day, we measured their gastric pH, looking for percent time that the gastric pH was above 4. That this group of medical students, normal healthy volunteers, if you will, were put on an appropriate timing and dosing of omeprazole twice a day, 20 milligrams. 5 of them had complete control of their gastric acidity, that is, pH greater than 4 for 24 hours. But only 5. That's what I thought the drug was supposed to do, or at least that's what we were told it was supposed to do. Look at the spectrum of the spread of the other subjects. So there's a great deal of inter-subject variability in response to a PPI. Subsequently, when lansoprazole became available, as the second PPI, this young man, Jan Hatlebach from Norway, spent a year in the lab with us. So he did the same study in a group of volunteers, only he had an omeprazole arm and a lansoprazole arm, and this was 30 twice a day, this was 20 twice a day, and he looked at the degree of time at the pH here, less than 4, if you will. Makes no difference, you can do it either way, of course. pH less than 4, and what I want you to take home with you is that, again, with the second PPI, there was the same amount of inter-subject variability, but there also was intra-subject variability from one drug to the other. So one of the points we made earlier, maybe the patient is taking the wrong drug. That is, the first thing you do is switch to another PPI. As this phenomenon began to be recognized, people asked the question, what about healing rates? Based on severity or grading of esophagitis, Los Angeles grades A through D esophagitis. There are over 5,000 patients in this nationwide multi-center study that I was fortunate enough to be involved with. And I don't want you to pay any real attention to the little differences between esomeprazole and lansoprazole. What I want you to do is recognize that healing, particularly for less severe disease, is about 90%, which is a figure that people often talk about. And as you get to more severe grades of esophagitis, the healing rates are not quite so good. So healing rates, let's settle on 90%. In that same study, when we looked at complete resolution of symptoms, in the first 28 days, it wasn't near the same. And here are the curves. Lansoprazole in yellow, esomeprazole in blue-green. 60 to 65% of the patients were had their symptoms under control at the end of the month, but only, again, 60 to 65%. That is to say 30 or 35% in this particular study were still having symptoms. We were just beginning to recognize that there was some breakthrough in the response. This slide came from a study of a number of meta-analysis is the word I'm looking for. From a meta-analysis by a group out in Tucson, Ronnie Fass and his colleagues. Basically, symptom response to any PPI therapy, non-erosive versus erosive esophagitis. Let's look at the erosive disease here first. PPI response, about 57%. Placebo, very small response. 57%, that's to say that 43% of these patients were still having symptoms. Symptom response to the NERD group, much less satisfactory, about 36% here. so 64% of the NERD patients, still symptomatic despite PPI therapy. So we were beginning to recognize even more so that PPIs were good, 90% healing, but they weren't perfect in terms of symptom control. So this was the algorithm that developed in my thinking, probably about 2003, somewhere along there. Patient presents to a physician in the U.S. with GERD symptoms, probably in Switzerland also with GERD symptoms. What happens? They get put on a PPI. And my perception is it makes no difference whether the doctor here is a primary care physician, an ENT, a chest physician, a cardiologist. They get put on a PPI. That's why you and I don't hardly ever see a patient that isn't already on a PPI. If it works, many people feel that confirms their diagnosis. I'm not totally comfortable with that, but that's kind of the general use of the drugs. And it's only these people that we see continuing symptoms despite a PPI or some complication. And of course, being gastroenterologist, what happens? You know, as my GI fellows have always told me, if you go to a barber, you get a haircut. Problem is, 90% of those are negative. That matches with what I've already told you. Healing in 90%. So these people now have been on a PPI for whatever period of time. They're still having symptoms. You do their endoscopy. Expect you're not going to find erosions most of the time. It's a low yield procedure. And that's been pretty well documented over and over again. Obviously, if it's positive, if you find eosinophils or continuing erosions, then you're going to pursue that situation. But so now we're talking about negative therapeutic trial, negative endoscopy. Here is where I want you to monitor for the reason for their symptoms. And I'm going to say to you, I want you to do an ambulatory monitoring with impedance pH while taking the therapy they're on, continuing the therapy. I'll come back and we'll talk about the controversies in just a minute. So the three options are, maybe you haven't controlled their acid. Not very likely, I'll show you that in a minute. You can almost take it to the bank that if somebody's on a PPI twice a day, their symptoms are not due to continuing acid reflux. Almost. Not 100%. And I'll show you that. Okay, then maybe their symptoms are due to non-acid reflux. And I'll show you that's true in about a third of these patients, and that number has stayed the same for the 10 years we've been studying it. And of course, maybe their symptoms are not due to reflux at all. Good possibility here. Let me remind you what we know about the mechanism by which people reflux. When I was a fellow, we were taught that this was the mechanism of reflux, that you had to have a weak valve. I'm showing you a pressure of about 5 to 6 millimeters of mercury here. Anything less than 10 would by and large be considered a weak valve. So you had to have a weak sphincter. That would be permissive for whatever's in the stomach, the reflux. Acid, pepsin, bile, or that pepperoni pizza that the patient just had. We're going to come back and talk about pepperoni pizza, so count on it. In the 1980s, in a paper in the New England Journal by the late Wiley Dodds and his colleagues, they basically showed that, wait a minute, most people with reflux have a normal sphincter pressure. Here I'm showing about 19 millimeters of mercury, but it spontaneously relaxes. They called them inappropriate LES relaxations. The common vernacular, as you know these days, is transient LES relaxations. That's TLESRs. That's an unfortunate term because a swallow induces a transient relaxation. So it isn't the transient part that's unusual, it's the spontaneous relaxation of that sphincter. And if you got a pH probe in the distal esophagus, you can measure reflux. So now we knew that there were two things that could be going on, and in fact, most of the world now believes that this is the major mechanism by which reflux occurs. And let me go back for a minute. And the most likely scenario that induces more of these is what? Filling your stomach. And we'll talk about reflux is a postprandial phenomenon. The bigger the meal, the more of the reflux. Well, this is actually, as I look back on it, more than 10 years later, was a seminal study. Marcelo Avila, many of you know, he was here for a while. He was at the graduate hospital with Phil Katz and I as a resident. And his colleague, a man named Radu Tatuyan from now Switzerland, was also a resident. And this was their study. As residents, they said to Phil and I, okay, we want to look a little more about what's happening with reflux, and we want to measure not just the acid, but the non-acid component. And oh, by the way, we've got this new probe that measures impedance. And it was one of the first studies ever done of impedance. In fact, it was so early in design that the impedance catheter had 22 rings, 22 metal rings, spaced 2 centimeters apart, so that you could measure impedance from the bottom to the top, or from the top to the bottom, if you will, of the esophagus. And we put a pH probe down next to it. They weren't connected yet, so it's kind of a Rube Goldberg type of thing. And what basically Marcelo and Radu did was to line up 12 GERD patients, 12 people who had chronic reflux symptoms. And they brought them in for a postprandial session. They gave them a meal that would induce reflux. And many of you know what that is. That's an egg sausage biscuit and a carton of chocolate milk from McDonald's. That's 61% fat. That will make almost everybody reflux. But just in case it didn't, after they fed them the meal, they had them lie on their right side for 2 hours. So the goal was induce reflux. Let's see what we can measure. Let's see what kind of reflux is going on. So remember, 12 patients, they had been on PPIs. They stopped their PPI for a week, studied them on day 7. Here's what they found. In this 2-hour postprandial period in 12 patients, total number of reflux episodes, 217. Most of them were non-acid. Even off therapy, most of them were non-acid, because the meal, as you know, buffers the gastric material to well above 4. So for that first hour or so, yeah, Darren, do you reflux after you get one of those McDonald's things? Ask him, he'll tell you about it. Most of them were non-acid. In the second hour, as the stomach acidified itself, then you began to see some of the acid reflux. Then they put the patient back on their PPI. And on day 7, they repeated the study. Got rid of the acid reflux. Did not alter the number of reflux episodes. 261, not significantly different from 217. And of course, now it's all non-acid reflux. So on the PPI, they're still refluxing, but it's non-acid material. It's the first time this has really been shown. And it really summarizes the whole message that I particularly want you to take home with you. But I'm not going to quit yet. Okay, Wojtek Błąski. Wojtek is from Poland. Spent 1.5 years working with us here. Extremely likable, extremely bright young man. He wanted to know what happens over 24 hours, looking at the same kind of technology. So this is his study. He's got 70 patients here that have 24-hour impedance pH monitoring while taking a PPI. And he's got 40 patients that have the study done off their PPI. They're not the same patients. 2 different study groups here. It was actually a retrospective look at a lot of data that we had. The graph basically shows the total here is the 24-hour data, episodes per hour. And you'll notice that on therapy, the average number of episodes per hour is about 1.7. And off therapy, it's about 2.3. And that was just significantly different. So there really is a little more overall reflux off of a PPI than on a PPI. But the important thing is look at the postprandial. This was 2 hours after the major meal in each one of these patients. It's exactly the same whether you're on a PPI or off a PPI, 4.7 basically episodes per hour. So the slide tells you a couple of things. One is that reflux, yes, is primarily a postprandial phenomenon, that you go from 2 episodes per hour to 5 episodes per hour, that it makes no difference in the number of reflux episodes whether you're on or off a PPI. What does change is what? The acidity of the reflux site. So here on therapy, most of it, the yellow portion, is non-acid. Here off PPI, most of it, the green part, is acid. Now let's dissect it a little further. I find these graphs really very compelling. We had a young resident here by the name of Carlos Zapata. Anybody knows much about medicine in South America, you'll know that his father is the best known gastroenterologist in Chile. Carlos was up, spent a month with us, and his job was to go back and look at 300 patient studies and identify the hourly rate of reflux. So this is from 6 a.m. to 5 a.m. It's a circadian cycle, if you will. And the histogram shows the number of reflux episodes in 100 patients off PPI. And I want you to notice the shape of that curve. Most people, of course, had very little in the morning because they came in fasting and the catheter was put in place early on. You get a burst of reflux after lunch and another burst after dinner. And contrary to popular belief, not really so much overnight. Nighttime reflux, in our experience, not near as common as people talk about it being. So there's your circadian cycle. Again, off PPI. So the red portion of each bar is the acid reflux episodes. And you can see it's pretty equal acid and non-acid. A lot of these non-acid because the meal is buffering the acidity of the reflux site. Now let's keep that in mind and let's compare that with 100 patients on a PPI once a day. Again, not the same patients. These are retrospective studies. 100 patients on a PPI, one a day in the morning. The curve is remarkably similar. The numbers are remarkably similar. The only thing that's really different is what? The acidity. So on a PPI once a day, almost all of the reflux is non-acid, the yellow portion of the bar. And again, very, very little at night. And then finally, 100 patients on a PPI twice a day. Doesn't really make much difference. Keep in mind that there's very little evidence, despite the fact that we all do it, very little evidence that twice a day PPI is better at anything than once a day PPI. So here's your twice a day data. Again, 100 individuals. This has never been published, by the way, because he went back to his residency. But very similar graphs. So what we learned with all of this was PPI therapy and GERD, basically this. Reflux is a postprandial event. It's when the patients have their symptoms. It's when you want to control things. PPI therapy does not change the mechanism by which reflux occurs. Why would you ever think it would? Therefore, PPI therapy does not stop postprandial reflux. It only changes the pH of the reflux site. So if your patient's saying, yeah, I'm still regurgitating, that's what they're doing. They're still regurgitating. A refluxer is a refluxer. I want you to think about pepperoni pizza and beer. So if I've got a patient that's a regular refluxer, and I bring him in and I sit him down here, and I give him a 10-inch pie and a liter of dark German beer, will that give me reflux? I guess she's smiling back there. Of course it will. Dark German beer and pepperoni pizza. The patient's going to get reflux. Now I put him on a PPI for a couple weeks. Let's do twice a day. And I bring him back and I give him the same pie and beer, what's going to happen? They're going to reflux. It just won't have any acid in it. So yes, acid doesn't get rid of the reflux. It gets rid, or PPIs don't get rid of the reflux. They get rid of the acid. So let's just kind of summarize here for a minute. In the mechanism of reflux disease, the role of acid is well established. I don't want you to think this is not an acid disease. It is an acid disease. Acid causes symptoms, acid causes injury, but we have drugs available today where we can get rid of that acid. Come out of the lab sometime and we'll show you patients that have 0 time with pH less than 4 in the lab. So you can get rid of it. However, in many patients, symptoms continue. It took us a while to recognize that. But you get acid control and the patient still has symptoms. Yeah, you may get rid of the burning, but you don't get rid of the reflux. So the question, of course, is could non-acid reflux be responsible? And the answer, of course, is a resounding why not, because the reflux mechanism has not been changed. So again, acid reflux, by tradition with pH monitoring, that's defined as a reflux episode of a pH less than 4. Non-acid reflux, I like to use the definition anytime you got reflux of a pH above 4. Some people argue for weakly acidic reflux, if you will. That is a refluxate with a pH between 4 and 7. And yes, I know that in chemical terms, a pH between 4 and 7 is still acid. But in GI terms, a pH above 4 is non-acid. So we like to use pH 4 as our cutoff, respecting the original pH studies. It's normal postprandially because the stomach contents become neutralized for about 1 to 2 hours after a meal, again, depending on the size and the protein content of the meal. It's augmented on PPI or H2 blocker therapy, where those meal effects are prolonged, and sometimes you can control it throughout 24 hours. So how do you identify it? And you all know the answer, of course. We do monitoring on therapy. Now, as PPIs became available and we were doing pH monitoring with a single electrode here, 5 centimeters above the lower esophageal sphincter, we could identify reflux. When the patient was on therapy, however, then it became a different challenge. So we added a second pH electrode on the catheter, 15 centimeters between those two, so we can measure esophageal acid and gastric acid. And I could use this one to ask the question, well, how effectively am I controlling the gastric acidity? And I could use this one to ask the question, and how effectively am I controlling the reflux? Unfortunately, limited to only the acid reflux. So we modified this. We added a whole bunch of metal rings up here. These are 2 centimeters apart. And if you measure the electrical current between each pair of rings, that allows you to measure impedance at 3, 5, 7, 9, distal, 15 and 17 centimeters approximately. You can put them anywhere, of course. This is just the way the conventional impedance pH monitoring developed and evolved. So I now had a catheter that let me identify gastric acidity, identified any residual esophageal acidity, but also identify whether there was reflux by looking for changes in impedance. This we call an MEI-PH catheter. That's not an M2, by the way. That's an MII, stands for multi-channel intraluminal impedance. And for those of you that haven't looked at one of these, and I know most of you have, because I beat you over the head with them, here's a couple of pH. pH. See, we were talking about pH for so many years, you can't get it out of your vernacular. Here's a couple of impedance reflux episodes. And I'm only showing you the impedance sites. I'm going to add the pH down here in a minute. So remember, 3, 5, 7, 9, 15 and 17 centimeters above the LES. If you look at the baseline impedance, you'll see it varies from over here it's about 1,000 and over here it's about 6,000, and the units are ohms. Remember, it's a measure of electrical resistance. Baseline impedance here. When reflux occurs, there's an abrupt drop in impedance because the refluxate coming out of the stomach has a high ionic content and it enhances the current. So as the current is enhanced, the resistance, impedance, if you will, goes down. And let me mark that for you just so you can see it. Now those of you that know my computer skills know I didn't do that. Radu Tatuyan did that before he left back to Switzerland. But there's a couple of reflux episodes. As we began to do these studies, we learned two things. One of them was that reflux, when it occurs, goes up the esophagus very quickly. We used to think it slowly worked its way up because standard pH electrodes only sample once every 5 seconds. Here we're sampling 50 times a second, or 50 hertz. So we saw that reflux sweep up there. Not a surprise, because if the mechanism is that your sphincter pops open, transiently relaxes, if you will, the pressure in the abdomen is greater than the pressure in the chest. So things are going to quickly be forced up into the chest. Second thing we learned was that it often goes proximal. So when your radiologist says to you, oh yeah, there was barium up around the clavicle, don't get too excited, because you'll see that at least a third of the reflux episodes when you're doing impedance monitoring. Not an unusual thing. Let's add the pH to it. Again, we've got the esophageal and the gastric pH. The dotted line is pH less than 4. On the left of this patient, on a PPI, you can see that there's breakthrough. The gastric pH is down around 2. And when that reflux occurs, there's the esophageal pH drops down to around 2. That's an acid reflux episode, and I didn't need my impedance to see that. But on the right, this patient also on a PPI, gastric pH a little bit above 4 here. Esophageal pH never gets close to 4, stays above 5. When that reflux occurs, that's an example of non-acid reflux. Those are the things we were starting to see here. A lot of this technology was developed in this institution. So how do we report this sort of thing? We argue about this a lot. One of the things we try to do is to be user-friendly. That is to send out something that the referring physician can work with, understand, grasp. So 24-hour impedance pH METRY on PPI therapy. What does our clinical report summary look like? Well, it has 4 components. First of all, we're going to comment on the adequacy of the gastric acid control. Do I need to give more PPI? Am I giving enough PPI? What can I do there? Secondly, we comment on the esophageal acid exposure time. Is there acid getting up into the esophagus? And that's kind of been the standard of evaluation for many years. Thirdly, we will measure the number of total reflux episodes and separate them into acid and non-acid reflux episodes. So how much reflux is still going on? And then fourthly, something that we put a fair amount of stock on, and many people argue about, and I'll come back to that in a minute. What is the frequency and the type of symptoms? And what's their association with reflux? So a symptom index, a symptom association, probability, whatever. All right, let's go to the gastric acid for just a minute. So here's what this actually looks like. And these slides were put together by Janice Freeman, who you all know that runs the lab. She's very, very good. Excellent gastric acid control. Here's gastric pH over 24 hours here. Here's esophageal pH over 24 hours there. This gastric pH never really truly gets below 4. It dips down a little bit there. The esophageal pH, therefore, never really gets below 4 or stays there. So a little something going on there. It's by and large noise. We would call that excellent. So we developed a qualitative scale that Molly McVeigh did a poster on at the college meeting last year, I believe it was, or this year. ACG last year. So this would be an excellent one, and you can see what the mean pH of the stomach was and the percent time that the pH was less than 4. The next cut would be good. Good is where the gastric pH is essentially controlled well, and there's some nighttime recovery, sometimes much more even dramatic than that. It's what we call nocturnal acid breakthrough. Showed that years ago when we were still in Philadelphia, that most people on a PPI, even twice a day, will have some acid recovery overnight. But it's not a problem if they don't have any acid in their esophagus, as we saw here. So good means esophageal acid controlled pretty well day and night. Gastric, a little bit of nocturnal breakthrough. Fair, you can see the difference. Now we're starting to see a lot more breakthrough of acid in the stomach. Here's some at night, here's some more in the day. And some of this is being reflux, particularly here. And poor means that it looks like they aren't taking their medicine. It looks like somebody being studied off therapy, where the gastric pH is here a meal, buffered by the meals, and the esophageal pH drops below 4 a good bit of the time. The correlation between that qualitative assessment, excellent, good, fair, and poor, if you put a number on them, 4, 3, 2, and 1, is very strong relative to either the mean or the median pH and the percent time that the gastric pH is less than 4. So we use that as an expression of gastric acidity. And interestingly, it's pretty well distributed. Here's the distribution of the 374 patients of the 4 types of assessments. And here's the mean and median pH in the stomach of these patients with the different scales. Okay, so basically what have we found here? Intermani, most of you probably don't remember. He was a research fellow with me for a year and a half from Belfast. Fascinating guy, very bright, very nice to have around, but inexpensive time here. And we had just gotten to the point where we had impedance pH available, and we could actually collect a series of patients. So prospectively, we collected data on 200 consecutive patients that came in with the question of, is the symptom that I have, or the reporting doctor saying, is the symptom that my patient has due to ongoing reflux, despite PPI therapy? All of these people were studied on a PPI twice a day. We'll talk a little more about that, but the bottom line for me is that that's what I'm trying to find out. So when somebody sends me their patient who's a PPI failure, if you will, I'm going to test them with impedance pH on therapy for 2 reasons. The impedance pH test allows me to measure any ongoing reflux because I have the impedance technology. I do it on therapy because that's the question that's being asked. Why is my patient having symptoms despite the PPI? So 200 consecutive patients. When we put that catheter down, the last thing we say to the patient before they leave the lab is, if you know what brings on your symptom, Mrs. Jones, do that today, because your doctor wants to know what's going on when you're symptomatic. And some people will wear this on the treadmill. They'll go out and eat things they haven't normally eaten or whatever. So the goal is to try to pair symptoms with reflux. And we did pretty well, because of the 200, 86% of them had symptoms during the day of testing. I have to tell you that there's very few things as frustrating as to have a case where you really want information, and the patient comes in, hands the recorder back to Janice and says, well, I had the best day I ever had, and no symptoms today. And you look at them and you want to say, great, the catheter is working, we're going to leave it in. But we haven't done that yet. Anyway, let's look at the 172 patients that are evaluable, if you will. 35% of these patients for non-acid reflux. That's been a consistent finding now for years, 35%. Remember I told you earlier that if they're on a PPI twice a day and they're still symptomatic, you can almost guarantee that that their symptoms are not due to reflux, because ongoing acid reflux on BID PPI, positive symptom index, only 8%. Now, about a third of these patients in our lab, and the way I approach deacidifying them, if you will, about a third of these patients were, besides getting a PPI twice a day, were also getting an H2 blocker at bedtime. And if you, and again, that's controversial, as many of you know. It just happens to work, by the way. But if you trace them down this way, the 70-odd patients that were also taking an H2 blocker, that number becomes 0. So if you really want to get rid of the acid, that's what I would suggest you do. Now, you've already figured out, of course, 35%, 8%. The majority of the patients, we did not identify a symptom association of their continuing symptom with reflux. 57% negative. When we first began to see this, it was kind of a bummer. You know, we wanted the test to be positive more of the time. It turns out that more and more people around the world that do this kind of testing and see these kind of patients recognize that that's, in many respects, the most helpful finding you can get. It allows you to say to your ENT colleague, this is not reflux related. This throat clearing is not a reflux symptom. Look for some other explanation. And that's becoming increasingly recognized. Now, at the same time, in fact, a month earlier, darn it, it's really kind of funny. We published, I don't know if you noticed, but Maney published his paper in Gut, because he's from Ireland, from Northern Ireland, and it really was better for him. Well, a month earlier, Frank Zerbib from France published his work in the American Journal of Gastroenterology with similar kind of results, smaller group of patients. But he looked at people both off therapy and on therapy, again, different patients. Let's look at this group. This is what compares to our 200. 60 patients studied on PPI therapy. They found a little more acid reflux, about 20%. That's a symptom association probability that they're using. About 20% positive. They were not giving an H2 blocker at bedtime. So it's likely they wouldn't get as good acid control. Symptomatic non-acid reflux, oh my goodness, 32%. Anybody remember what we had? 35%. Almost exactly the same. And they made the point that regurgitation and cough had the most frequent association with non-acid reflux, and we would tend to agree with that. Those are two really critical symptoms. Well, you know, it's not all light and happiness. Like many things in medicine, as you find things and you develop theories and concepts, the other experts are going to fuss with you a little bit. So what are the areas of controversy? Well, reflux testing, should you do it on or off therapy? I told you why we do it on therapy, because that's the question we're being asked. Many people say, no, I would rather stop the PPI, put it over Bravo, because that's easier on the patient. Not so much, really. But that's one of the ways of thinking. And it's a reasonable one. What you have to keep in mind is if you stop the PPI and test, and it's negative, that will correlate very well with the on PPI testing. So a negative test off therapy, normal amount of reflux and a negative symptom association is a strong finding. A positive test off therapy still doesn't answer the question you're trying to answer in the first place. That is, why is a patient having symptoms on therapy? So that's part of the argument. Another area, how do you document reflux symptom relationships? Do you do a symptom index? Do you do pH only? Do you do pH combined with impedance? I showed you two studies, one where we did the symptom index, which is really the equation between reflux episodes symptoms preceded by reflux divided by total number of symptoms. or the symptom association probability, which is a statistical test that gives you the likelihood that the relationship you see could happen by chance or not. Important question. Is symptomatic non-acid reflux clinically important? Many people trivialize it. The argument being, if I can get rid of the acid, which is what causes the damage, why should I care? Well, excuse me, but the patient cares. They're the one having the symptom. So if you can work all that out and get rid of it, yeah, you've healed the esophagitis, but there's still symptoms. And then the big question, and you folks have all by and large been in the clinic with me, is there an effective therapy? And some of the tricks we have to play. Here's the symptom index. Again, it's simply the equation between reflux positive symptoms and total number of symptoms, and if it's greater than 50%, the consensus is that that's the cutoff for a positive test. We actually first published this out of Wake Forest when Richter and I were there together in 1988, used around the world pretty regularly still. The symptom association probability is done by your computer, and it basically looks at the data and it divides it into subsequent 2-minute segments for the 24 hours. And then it simply constructs a 2x2 table. Symptom present in that 2-minute window, yes or no. Reflux also present, yes or no. And it does a Fisher's exact test or a chi-square type of study. And if that's 95% or greater, that's considered positive. That's akin to doing looking for a P less than 0.05, if you will. Well, we compared them here. There's a lot of arguments about which one to do. We looked at 200 consecutive impedance pH studies. The good news is that the symptom index and the SAP agreed 72% of the time. Most of that being negative. Again, the increasing recognition of the strength of that negative study. When they disagreed the same amount in both directions. Quirk of the SAP, because you have to plug numbers into those 4 cells to do the chi-square, is that if any one of them is 3 or less, then it's going to give you a 0. So if your symptom associations are less than 3, yeah, it doesn't work for you. There's been one outcome study done out of Iran by Tagavi et al. That found, compared to the response to PPI, that the most sensitive test was the SAP and the most specific test was the symptom index. So we, by and large, look at the symptom index for the reasons shown here. But we need more outcomes data, and it happens regularly. Now, we did a second group of 200 patients. In the later years, Rod Sharma, who many of you know, spent a year with me. I think he spent 2 years with me. It took him a little longer to learn. Don't tell him I said that. 2 years in the lab. And again, he wanted to look at 200 consecutive patients. We were asking some different questions now. You know, we knew the frequency of positive and negative and whatever, but just what were the symptoms and how did they vary? That we find in these people that are being sent in by the referring doc asking the question, is this residual symptom due to reflux? So in order to get 200 that had symptoms during the study, he actually had to screen through 218 consecutive studies. 18 of them were symptom negative. And of the 200, 100, exactly half of them, had reflux only of non-acid material, only non-acid reflux. So the PPI therapy was completely controlling their esophageal acid. The other 100 had a mixture of acid and non-acid. And when you come down here again to a positive symptom index, 70 patients, 35%, had a positive symptom index for non-acid reflux. So that's 4 years later, different group of 200 patients, exact same figure. And when you look at the acid reflux, acid alone or acid Mixed with non-acid, it's another 7%. So again, reinforces what I said earlier. If the patient's still symptomatic despite treating their acid adequately, it should not be from acid reflux. It should be non-acid. Negative, 58% again. So kind of confirm what we knew. This was the part we were interested in, just what were the symptoms? And this is the distribution. Now notice that there were 200 adults, as I told you. With the monitor, you can identify up to 3 symptoms that are being evaluated. So that makes a potential for 600 total symptoms. There were 415 total in these 200 patients. And that's basically what this distribution recognizes. And basically, we kind of, when we think of reflux, we think of heartburn or regurgitation as the typical symptoms, of course. And you can add chest pain, because a lot of people confuse these two. So here are typical GERD symptoms, about half of a pie. The other half are what we would call atypical GERD symptoms. Cough, throat clearing, little nausea, and some other noise is shown down here. But that was the distribution of symptoms, so that heartburn and throat clearing were the most common and continue to be. When we looked at the symptom index positivity rates, percent positive symptom index, no surprise, heartburn and regurgitation were the highest positivity rate, over 50%, but only 50%, by the way, positive, which was kind of a surprise, and I'll come back to that in a minute. Here's where the atypical symptoms, cough and throat clearing, around 18 to 20%. So if you were to ask me, how often do you find positive testing in somebody with chronic cough, I would tell you about 20 to 25% of the time. I'll show you another piece of data with that. It's important because worldwide people are recognizing that cough can be an important residual symptom of non-acid reflux. Here was an addition to Roger's data. We added another 50 patients, so we brought that total up to 250, and went back and not only looked at just the symptom index positivity, but also did the patient have an excess number of reflux episodes. Defined as excessive would be greater than 48, that's 2 per hour basically. Normal would be less than 48. And this is the way the algorithm came together. 250 patients, symptoms of twice-a-day PPI. 42% had a positive symptom index. That's 35 and 7 from the last group, as you may recall. And if we go down this arm, so here's positive symptom index, excessive number of reflux episodes. That was 31 patients, or 12%. Those for sure have reflux. We call them true refluxers. This group was interesting because people talk a lot about this phenomenon. Positive symptom index, but a normal number of reflux episodes. That's a big group, 30% of the total. That's what people call a sensitive esophagus, if you will, or esophageal visceral sensitivity. Over here, negative symptom index, the biggest number, for 58%. This group is hard to really get your hands around, but it's very, very small. Negative symptom index, but excessive number of reflux episodes. It's only 10 patients, was 4%. We couldn't figure out what to call them, so we called them insensitive. I'm open to suggestions. And then finally, the biggest group, negative symptom index, normal number of reflux episodes, 54% of the total. This is where functional heartburn comes down. This is where your extraesophageal referrals from ENT occur. And the good news is that you can now comfortably send these patients back because there's enough assurance with the testing to say this is not reflux. Look for another etiology. And when that has been done, studies by Mike Viesi out at Vanderbilt, 2/3 of the time, they have found another explanation for the symptoms. All right, I'm about ready to quit. Let me just come back and pick up a couple of things. So the 172 patients from that original study who had symptoms during monitoring, we separated them again, like I just showed you, into typical and atypical. Typical GERD symptoms here: heartburn, regurgitation, chest pain. 99%. Of them, 48% non-acid reflux, 11% acid. That's 59% positive, as you would expect, for heartburn and regurgitation and chest pain. And many of my colleagues who don't like the testing will say, well, I'm a good clinician. I can recognize that. I don't need your test. And of course the response to that is, well, that's fine if you don't mind being wrong 40% of the time, because you will be. But notice this, when you look at the atypical symptoms, now they're almost all negative for a reflux association. Almost. So you can kind of, again, take it to the bank. All these ENT patients, even the cough patients coming from pulmonary, unlikely that they're going to have reflux, and a big significant difference between the two distributions here. But you can't just ignore it because of these. Cough, chronic cough, lives right there. And it's one of the most delightful things you can do, is to see a patient who has a chronic cough, suspected as being due to reflux, hasn't responded to a PPI, no longer goes to restaurants, no longer goes to the symphony, no longer goes to the theater, doesn't go to church because of the cough. Identify that it's reflux, and most of them we've sent to surgery, and I'll show you that in just a minute, and it all goes away. Very gratifying. Now here's something you need to know. Not that the other wasn't, but Andre Smout is one of the best investigators in the world on reflux disease. He lives in the Netherlands. This is a study from his lab. By Woeston was a fellow working with Smout. And they took a single catheter, put it down the esophagus. There are 5 electrodes on this catheter: 3, 6, 9, 12, 15 centimeters above the LES. And this was an attempt to address this whole concept of proximal reflux, proximal monitoring, that a lot of people feel passionate about, mainly in the ENT world. And here's what they found. Here, this is one example of a reflux episode. It's published with that article. At 3 centimeters above the LES, here's a for sure reflux episode. It just clears and then it comes on again, and we would call that acid reflux. Not an uncommon thing to see. At 6 centimeters, you really saw the same thing. Same amount of acid exposure, time less than 4. At 9 centimeters, you lost this component. At 12, you still measured the major part of the reflux. But at 15 centimeters, for the same reflux episode, you wouldn't even measure it if you're looking at pH less than 4. So as that reflux moves up the esophagus, it gets diluted, loses some of its acidity. So much for proximal monitoring. We don't do it, as many of you know, except to that impedance level. But here's the cough. This is a representative sample. Everybody know what that means? So when an expert gets up there and says, this is a representative sample of our data, definition, this is the best I've ever seen. Nobody shows you their bad ones. So here's a representative sample. This was done by Tutuyan, monitoring this patient with chronic cough. Here's the impedance change going all the way up 17 centimeters above the LES. Here's the pH in the distal esophagus. Only got down to around 7, believe it or not. And there's the positive symptom associations. So it's non-acid reflux, positively associated with a cough. What Radu did was to go back and collect 50 consecutive patients that we had studied with persistent cough, that we did impedance pH monitoring on therapy like we do, 32 of them on a PPI twice a day, 18 of them on a PPI plus a nighttime H2 blocker. Positive symptom index, going down this side, that is greater than 50%. 13 of the 50 patients, that's 26%. Again, remember what I told you, positive cough, 20, maybe 25% based on this study, but important finding. Laparoscopic Nissen fundoplication, 6 patients here, done by David Adams. Mean follow-up, 9 months when this was published. They were all asymptomatic and no longer taking a PPI. Not a controlled study. Hard to do. We got one going on the VA. Don was working with Stu Specker on that, you know that. Hard to get entry, boy. Tough study. So we concluded that a fundoplication may be successful in patients with atypical GERD symptoms who failed PPI treatment if the positive symptom index is found for non-acid reflux. So if your testing indicates what you're dealing with. Now Jason Roberts, before he stopped working with me, Jason was in the lab for a year. I lost him. I thought I was going to make an esophagologist out of him. That's hard to compete with those endoscopes. Jason put together this study, presented at DDW 2009, yet to be published. And basically what he and Janice did was to identify patients who had 5 symptom events that were clearly associated with reflux. Within that 5-minute window, they were preceded by a reflux episode. So they were positive, if you will. 10 patients, it was 5 coughs. 10, it was 5 throat clearing. 10 regurgitation, 10 heartburn. So there were 50 total symptoms of each of the 4 types. Then the tracings were shuffled, and the type of symptom was removed from it. And they were given back to Jason to read, so that he was completely blinded as to the specific symptom that was preceded by reflux. Again, they were all reflux related, but he didn't know which was which. And he looked at the height of the reflux, again, because of this recurring question of proximal monitoring give you the answer. So 7 centimeters, 9 centimeters, 15 centimeters, 17 centimeters above the LES, there is no difference here in the height of the reflux, whether your symptom is cough, throat clearing, regurgitation, or heartburn. Non-acid reflux and extraesophageal symptoms. Big discussion. There's good news and there's bad news. Yes, a positive symptom association may occur. I showed you our 50 cough patients as an example. However, most cases, 75 to 80% will be negative. I showed you that. You can't ignore them, however. You need to separate out the ones that are from the ones that aren't. And in those negative patients, look for another etiology. They do pretty well. All right. I need to quit, don't I? Anybody wants to get up and leave, get up and leave. Let me just quickly run through the therapy stuff. This is where it gets frustrating. This is what keeps me up at night. So what do you do to treat these patients? You know, PPIs are so wonderful, and you can get rid of the acid reflux. But once you've done that, I want you to think about reflux reduction therapies. And of course, I've shown you already, we've done more fundoplications since we started looking at non-acid reflux than we did before we did. And by the way, Don, I was on a conference call with Stu Specker last week about that VA study, and he actually made the comment that fundoplication is a good thing, a good procedure. I've never heard him say that before. So maybe we're making progress. So fundoplication, everybody know what a lynx is. That's that band of magnets that you put around the bolster up the sphincter. I don't know if that works or not. David is doing some. Maybe we'll learn something. Is there an endoscopic way to stop reflux? I don't know. I've watched that for 25 years. You know, things have come and gone and come and gone, and the most popular one right now is the so-called TIF procedure, an internal fundoplication, if you will. Don't know if that works. So what do we do as internists? What are our tricks? Well, baclofen truly does decrease transient LES relaxations. But I got to tell you, when I talk at one of the national meetings and I got a room full of gastroenterologists and I say, how many of you have used baclofen in the last 6 months to treat reflux? 2 hands go up. Needs to be tried. Has side effects, yeah, they're CNS related. Dizziness and drowsiness are 2 of the big ones. We start slow and start low and go slow. What Doug Drossman taught me years ago. Start out low and work your way up. Pathanochol. Why would I use that? Again, maybe 1 hand goes up when I ask about that. Pathanochol. It is a cholinergic mimetic drug. Will stimulate acetylcholine receptors, will increase esophageal peristaltic pressure, and raise the resting LES pressure. I don't know, because there are no data, what it does to transient LES relaxations. But I do know this. Oh, I'm sorry. I mean, to finish the list, I'll come back. What about improving gastric emptying? Well, metoclopramide is such a bad drug, as you know. We don't use it much. We preferentially find ways to get domperidone for the patients. We like that a lot more. So if their gastric emptying is bad, that's a reasonable thing. And then finally, really, the antacid of choice, I believe, should be Gaviscon, because of the alginic acid that interferes with reflux, gets in the way of it physically. There's better Gaviscon in Europe than there is here. So-called Gaviscon Advance has more alginate, and I'm hoping we'll get that here. Many people have argued again, if the acid is gone and you're no longer injuring the mucosa, why not just change the patient's awareness of their reflux? Consider a visceral analgesic, if you will, like a tricyclic antidepressant or an SSRI or an SNRI. Not a lot of data on that, not much, very little controlled data. Here's one small study that was done with baclofen. 4 places around the world have shown that it works. One of them done by Marcelo Vila in the US. But there's a small group of patients. They did placebo and they did active drug, and they showed a positive effect with a minimal amount of side effects, but a small study. There's a drug being developed in this country called baclofen, which worked like baclofen but had less CNS effects. And basically what this curve shows is that when you look at symptoms in 15-minute intervals and number of reflux episodes in 50-minute intervals, that the active drug, that is the blue curve, showed less symptoms and less reflux episodes over the course of 2 meals in a 12-hour study here. Very promising, but the drug company was a small startup company, and nobody's bought the drug from them, so there's probably kind of a message there. And then it's funny, one day I woke up and I said, wait a minute, we actually did a study back in the 70s. It was so long ago I couldn't remember it. A randomized controlled trial, you know, all of the good things. An RCT of 20 patients with chronic heartburn, defined with a LES pressure less than 10, and a positive Bernstein test. Anybody know what that is? Where we dripped a little acid down there. Remember, in 1974, we didn't have PPIs. We didn't have ambulatory monitorings. This is how we documented reflux. And everybody was randomized, 8-week crossover with either Pathanochol 25 QID or placebo, and significantly improved both their heartburn scores and the PRN use of antacids in this trial. Never went anywhere. Presented at DDW at the plenary session. Never went anywhere because the next year Tagamet came out. and the world changed. Anyway, Fanical is an interesting drug. And then finally, here's the surgical result that Indermani published in the British Journal of Surgery based on testing patients that David Adams did. This is not a controlled study. It's very hard to randomize a group of private patients to a control of this kind. 19 patients based on their pre-op and PATH studies that is a positive symptom index. 14 of them had non-acid reflux with symptoms. One failed. One relapse was an ENT patient with horses. One was lost to follow-up. 12 out of 14 got better, stayed better. We followed them up for 14 months. Oh, here it is. 14 months, by the way. 4 patients had acid reflux-related symptoms. Again, all 4 of them improved off PPI, so very good results in that group. Here's the one patient that never had reflux in the first place. Got operated on, don't know how that happened. Wasn't really our patient. So overall, the success rate was 94% with surgery. And I just want to conclude. Let me conclude. How do I conclude? All right. If I go back and look at that algorithm we talked about at the beginning, patient with GERD symptoms, trial of therapy, continued symptoms, you do your monitoring. Let's put the numbers back in the algorithm. Acid reflux, only about 10%. That's the least likely finding. Non-acid reflux, there's that 35% figure that keeps coming back to get us. The most likely possibility, however, is that the residual symptoms are not due to reflux. So basically, when you give PPI up here, you're doing acid reduction therapy. When you get down below acid symptoms, non-acid symptoms, I want you to think about reflux reduction therapies. And over on the right, you should encourage the physician to pursue another diagnosis. Now, I wrote an editorial back in 2008. I'm always doing things like this, where I said the combined impedance pH monitoring has become the gold standard for the measurement of reflux of all types. And most people would agree with that. One has to question why anyone would use pH monitoring alone. And if they do, they need to be aware of its limitations, because you'll miss the non-acid components, but you'll also overdiagnose acid reflux. Just imagine doing one of these on Ben Clyburn, somebody who's sipping a Coke all day long. Every time a swallow goes down, so does the pH. You think it's reflux. Well, Jan Tak and Blondeau out of Belgium, Tak is a very respected GI person in Europe, basically published this: combined impedance pH recording provides the same information as traditional pH and adds to it relevant information on the prevalence of non-acid reflux and the proximal extent and composition of the reflux events. When it is performed on PPI, the diagnostic gain is much larger and provides a tool to understand why treatment has failed. Again, the reasons why we do it on therapy. And then Phil Katz and Lauren Gershon and Marcelo Villa, as some of you know, just recently published the new ACID GERD guidelines, in which they said impedance pH testing covers all possible scenarios. A negative impedance pH test on medication strongly supports that the patient's complaints are not due to reflux of any type. And I think I'm going to quit. Yeah, I'm going to quit. There's a couple other slides there, but thanks for listening. If anybody wants to stay and ask a question, please feel free.